All right, so we're here with Marty Sanda. We're in one of our typical Weston conference rooms. Busy AUA, of course. One of the highlights, of course, is the updated prostate guidelines. As we were talking offline, moving up, the first version really only made 3 statements. Basically, the Bill Axelson study, dose-escalated radiation, and the BOLA study with hormonal therapy. We now have a guideline that's really structured differently, has over 60 independent statements. So, Marty, take us through kind of the construct of how you went about putting this panel together and organizing it.
Well, I think the key really was we engaged not just AUA, but as well SUO, as well as ASTRO, and we sought input from ASCO as well in terms of panel membership. We also had a consumer member. So it was a very engaged panel, and we did not rush it. We took our time. We've really been working on this now for a couple of years. And so we had the opportunity to take advantage of new evidence, high quality evidence, such as the PROTECT trial and other work that's come through over recent years. Having said that, a cornerstone of the guideline does remain the SPC G-Force trial, which is initially reported by Holmberg and then by Bill Axelson and others from Sweden, which provides very robust evidence for prostatectomy, radical prostatectomy as a care standard for intermediate and high-risk prostate cancer. And similarly too, now actually the PIVOT trial, which despite being a trial that on the one hand provided evidence against prostatectomy in lower risk prostate cancer, actually also provided some very compelling level 1 evidence for the effectiveness of prostatectomy in improving survival for patients with intermediate risk cancer, patients with PSA over 10. So those were some of the prostatectomy highlights. The big news really for the guidelines this time around is the continuing, emerging, and growing role of active surveillance. And in particular, not just for very low-risk disease, but also for low-risk prostate cancer. So I think that was an important component of it. The second new area for the guidelines that I think is very important and can be very practical in terms of the approach to the patient decision-making that can oftentimes be a scenario of the patient being in a situation of difficulty finding the forest through the trees. So the second important thing here, I think, was that we took on the notion of dividing intermediate risk prostate cancer into favorable risk and unfavorable risk. And in doing so, really embraced the new WHO, World Health Organization, prostate cancer grade group criteria, which involve most relevant to the guidelines, separation of Gleason score 3+4 cancers as having a more favorable risk pattern, and 4+3 cancers as having a less favorable risk. So that was an important caveat that impacts a distinction that impacts things like recommendations for staging studies, impacts things like when should hormonal therapy be used with radiotherapy, or when is it possible to do radiotherapy without hormonal therapy, and things like when is an appropriate time for pelvic lymphadenectomy with the prostatectomy. So a variety of decision tools or decision points are impacted by that favorable versus unfavorable risk scenario. The other thing that we really try to do is provide a gradient of the combination of evidence and strength of recommendation around each of the risk categories and around the different care options. So that with low risk, we wind up having a situation where with both very low risk and low risk, active surveillance winds up being the preferred option. With low risk that's not very low risk, prostatectomy or radiotherapy has some robust evidence that's conditional, and cryotherapy or other approaches are less well supported. In particular, HIFU or focal therapy, there's very little comparative evidence to really support those outside of a clinical trial. On the other hand, with intermediate risk cancer, the scenario, and with high risk, the scenario in terms of gradation of level of evidence and strength of recommendation, an important feature there is recognizing and really highlighting that the role of radiotherapy in terms of level 1, robust level 1 evidence with survival benefit is really been demonstrated only in the setting where radiotherapy has been given in conjunction with hormonal therapy, androgen deprivation. And so really the need to recognize that it's not really prostatectomy or radiotherapy that a patient is looking at if they have intermediate or high-risk prostate cancer as their best evidence choices, but it's prostatectomy or radiation with androgen deprivation. And the importance of that androgen deprivation component, I think, has been really emerged as very well recognized as a key feature that impacts quality of life and other issues in a way that really needs to be brought to the forefront, and that I think can sometimes make that decision point easier for patients and for clinicians.
How did you go about dealing with some newer ideas like genomic testing, imaging, sort of, rapidly changing field where sometimes the idea comes ahead of the evidence quality?
That's right. And we struggled with that a little bit because we recognize that there's a lot of potential for genomic markers, genetic markers, biomarkers that perhaps has not been yet validated, but stands to emerge in the coming years. So we were not able to make recommendations about use of, for example, genetic tests to help either monitor patients on surveillance or select them for surveillance at the current state of the evidence and what we know. But at the same time, we tried to really encourage the main forces in that field to embrace the notion of validation type trials, prospective studies, to better define the role of those markers. On the other hand, imaging modalities like MRI, there is some stronger evidence in that arena. And so we really did embrace MRI imaging, both in the context of a component of active surveillance potentially, as an option, a choice to include MRI in that, and on the other hand, as an alternative approach other than CT scan or such for evaluation at the staging setting for higher risk disease. So I think that there's some opportunity that we saw where it was ready to be embraced in the case of MRI to a variable extent, but still a lot more to be learned, particularly in the case of things like genetic biomarkers.
Yeah. Well, I think it's going to be a big hit, real help to the reader, clinical practicing. Obviously going to be well cited when we get it published, and the collaboration was really great to see with the other societies. So
I enjoyed it a lot. Thanks a lot, John, for your time.
perfect. All right, thanks, Marty.
All right, man.